the landscape of prostate cancer changed dramatically when abiraterone was first introduced. The mid 2000s, like 2006, something like that, 2004. And it was dramatic, and it was positioned after docetaxel. And what it proved was that prostate cancer is still driven by the androgen receptor. And so the position that we had taken, namely that it was hormone refractory or castrate resistant, was not true. It was still sensitive to the androgens being produced by the cancer cells themselves. So I always tell my patients, look, there's three foods for the prostate cancer that we know of that are male hormone related: the testicles, the adrenal, and the cancer itself. And Zytiga blocked all three, and as did the subsequent drugs, enzalutamide and apalutamide and now darolutamide. So those drugs established that androgen receptor remained a driver of prostate cancer for long periods of time, particularly if they were non-metastatic, the so-called NMCRPC, where first enzalutamide, then apalutamide, and then darolutamide got approvals. But the bottom line was that ultimately those cancer cells become androgen independent. And the hope was that they would be non-cross resistance, that you could maybe give abiraterone with enzalutamide and extend the duration of benefit. And so the ECOG with Mike Morris reported, I think it was last year, that the single agent versus double agent had no improvement in survival. No overall survival benefit for 2 versus 1. Mm-hmm. And then Kim Chi in Vancouver did a very nice study, not very many patients, 200 or so. All of them had gotten either Abi or Enza, and then he randomized them to the other agent, either Zytiga or enzalutamide, and basically showed that if you had enzalutamide, abiraterone second line was virtually worthless. There was a little bit of benefit of enzalutamide after Zytiga or after abiraterone. So we were in this kind of funny position where we weren't sure if there should or shouldn't be a second line androgen receptor blocker. So there is where the CARD study was designed. It was designed right around the time that we began to realize that the second androgen receptor inhibitor probably wasn't very helpful. We had data that suggested about a 3-month response rate, and single digit, maybe double digit, but no more than 10 or 15% response rate. So Ron DeWitt and my friends in Europe, under the pressure that the European medical boards were giving them to say, look, we're not going to approve 2 androgen receptor inhibitors. You get 1. And they said, well, maybe that's not the right decision. So they randomized these patients to, after the first line, either Abi or Enza, to get the alternative drug or cabazitaxel. Cabazitaxel won that foot race by a long shot. Cabazitaxel had a higher response rate, had a higher PSA response rate, had a longer duration of survival, and had a higher PFS. And it was almost double. So it went from like 3 months with Abi or Enza to about 7 months. And moreover, it was an overall survival advantage for the use of cabazitaxel. And now, in this context, that's wonderful news. The difficulty is that nobody uses cabazitaxel. It's like 14% of the U.S. medical oncologists use cabazitaxel. So I've been using it a lot, and I've realized that it is a a very well tolerated drug